Thank you for joining us today for the Geriatric Grand Round program. This program is provided by the Michigan Center for Rural Health in cooperation with MSU College of Human Medicine and MSU College of Nursing. Before we begin the program, please remember to keep your mic muted until the Q&A component at the end of the presentation. Please remember to mute your mic after you have asked your question so the signal is clear and so the presenter can answer the question. Handouts are located on our website at mcrh.msu.edu. Click on the education link across the top, scroll down, find today's date, and there you will see the attendance forms and evaluation link. However, our website is having some technical issues, so if you send me an email, I can forward you everything from handouts to attendance forms and evaluation. Continuing education is available for physicians, nurses, and social workers. Each healthcare discipline has their own attendance form and sign-in form, and everyone fills out the same evaluation by clicking on the link and completing it in SurveyMonkey. Attendance forms and or sign-in forms need to be emailed, faxed, or mailed into the Michigan Center for Rural Health office. Sign-in forms need to be signed by a proctor. Sign-in sheets need to be returned to the MCRH office, and the nursing attendance forms need to be filled out and signed by hand. Physicians, please note that in order to obtain your certificate, you need to do everything in the new CME portal. If you have any questions, please contact me. Please complete all of these forms within 2 weeks or by April 19th. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I'm pleased to introduce Dr. Linda Kyleman, who will be speaking on non-pharmacological interventions to pain. Go ahead.
Good afternoon, everybody. So basically, pain is a universal experience. It's a fundamental feature of being human. So evidence-based guidelines and recent reviews, a growing body of evidence emphasize the importance of pain assessment and management. Yet management of pain is extremely complicated, and adherence to the treatment plan can be a roller coaster for some individuals, especially older adults and their caregivers. So today, I hope that you learn how to define and recognize pain, especially in older adults, and then to identify evidence-based non-pharmacological approaches, or NPAs, for effective management of pain. And of course, this is Geriatric Grand Round, so we're going to focus on geriatrics. So I know that this slide was a little difficult for you to read, but all these boxes represent people with pain. This is the Institute of Medicine's picture of pain. So people can move between and among these groupings and can be in more than one group at the same time. You don't have a copy of this because it's copyrighted, but it's available to you on the web. So similar colors on the screen represent similar endpoints or outcomes, those within or those outside the healthcare system, and those with acute and or chronic pain. So the 2011 Institute of Medicine report talks about protection from and relief of pain and suffering. Pain is part of the human condition. In our lifetime, we will all experience pain, and some of us will suffer from its consequences. While pain can serve as a warning to protect us from further harm, it also can contribute to the suffering, surpassing whatever is causing the pain to actually become a disease in its own domain and dimensions. So we all may share common stories of pain, but in reality, our experiences with pain are deeply personal, filtered through the lens of our individuality, where we were born, where we grew up, where we lived, where we currently live, our personalities and coping styles that we've developed over the ages. So pain is a life journey that impacts and can be impacted by health and disease. So I want you to remember that and think about that as we go through the slides today. So what is pain? There's a variety of definitions in your handout and up on the screen. But acute and chronic pain affects large numbers of Americans, with at least 116 million adults in this country burdened by chronic pain alone. The annual national economic cost associated with chronic pain is estimated to be between $560 and $635 billion annually. That's a B, billion. And that's about $20,000 for every person living in the United States. So pain is a significant public health problem. It reduces quality of life and impacts some population groups more than others, especially older adults. It is uniquely individual and subjective experience that depends on a variety of biological, psychological, social, cultural, and spiritual experiences. Pretty much, pain is whatever the person says it is, occurring when they say it does. So it's an unpleasant sensory and emotional experience that the patient can describe. And then the healthcare professional must accept that individual's report of pain. So it really is a subjective experience, and there are no objective tests to measure it. We'll talk about some things, but it's pretty difficult. And whatever the person says it is. But what's wrong with the definitions and the concepts that I just talked about? There are issues. Some patients can't explain or give a self-report of pain verbally, in writing, or by any other means, like blinking their eyes or even answering a simple yes and no question. We can ask the question, but if they don't understand what we are asking, or we cannot understand them, what do we decide about the pain? We can see that pain is sometimes more than what the person says it is, because they cannot tell us in words or gestures what they are experiencing, and that makes a huge difference. So the personal experience of pain is often difficult to describe, and the words to describe pain rarely capture its personal impact on individuals. Severe or chronic pain can overtake a person's life, having an impact on individuals as well as on their family, friends, and the community they reside in. Older adults tend to underreport pain. They're more stoic. Think about when they grew up. They did things because they had to. They don't complain. They grew up in a time that was much different than today. And individuals with cognitive impairment, abbreviated CI, can experience pain differently. And their ability to use words or tell us where is impaired. Older adults, and especially those with cognitive impairment or dementia, are particularly at risk for not having their pain recognized or treated, especially if they're not talking to us about it. And we know that pain is undertreated in dementia. So they are also at risk for having multiple sources of pain. So I want you to look at the screen and just look at these pictures. What says pain to you on this slide? In those pictures, who do you think's in pain? How do you know? Do you see pain or fear, sadness, loneliness, depression, hopelessness, anger? What do you see? How do you look when you're in pain? If you're not telling somebody, can another person tell that you're in pain? Something to think about as we go through the information. So, what are the ways of describing pain or knowing that there's pain? Well, there's self-report. Since pain is individual, only the person knows what the pain is like for them. Injuries that look bad may not be that painful, and injuries or diseases that cannot be seen at all may be extremely painful. Just because you can't see the cause of pain does not mean that the pain doesn't exist. Self-report measures have often been underutilized in assessing pain. They can be used in conjunction with observer reports, which I'll talk about momentarily. And really, they can provide a valuable indication of treatment outcomes. Because if they say they were feeling one way when you're talking about pain, you provide a treatment or intervention, and they say something else, we have to use the person's own words, their own speech, not giving them words to use, so that we can measure it as objectively as possible. Another way is through the observer method. So an older adult with cognitive impairment or even dementia is more likely to express pain through changes in their behavior. Family members or longtime caregivers can be especially helpful in assessing pain by observing behavior changes because they're more familiar with the individual's normal behavior. Patients that I've had in my practice for the last 10 years, I know when they are different. They might not be able to tell me that there's something different, but because I know who they are, I am able to recognize that. So that is observation. So before children are able to speak, pulling on their ear, that's something that parents are taught that maybe their ear hurts. And generally, they probably do have some type of infection. But this pulling on an ear or part of the body can also translate to older adults or an older person who's not moving or guarding a part or protecting a part of their body may indicate to us without their verbalization that pain is present. So, and then it's also about how the body reacts. So pain can be assessed by measuring some of the body's physiological responses. So depending on how severe for the individual the pain is, we might see an increase in heart rate, breathing rate, blood pressure. Sometimes there'll be sweating, there can be redness, especially in the face. But these changes physiologically can also be caused by something else or in combination with something. So we need to use all of these things, self-report, observation, and then what means we have from a physiological standpoint together. So back in November 1998, the Veterans Health Administration decided that we should have a national strategy to improve pain management, and that whole plan was called Pain as the Fifth Vital Sign. We have temperature, pulse, respiration, blood pressure, 1 through 4, and then pain is the fifth vital sign, that we really should get into the habit of asking everybody whether they're experiencing pain or not. And then basically it was using a numeric rating scale, generally 0 meaning absolutely no pain, and generally up to 10, the most severe pain that you can imagine. So any score of 4 or higher would really supposedly trigger a comprehensive pain assessment and then intervention by a healthcare professional. So a lot of providers say that pain is not a vital sign. It's not a sign at all. So vital signs are what I just said. Temperature, pulse, respirations, and blood pressure, because they can be measured. But all the research that's been done on pain, we absolutely can measure pain in a variety of ways. I think controversy is good. I use pain as a fifth vital sign, teach all my nursing and medical students to use pain as a fifth vital sign, because at least we're thinking about it. And then we need to think specifically about it. And when we ask someone about their pain, it allows them to feel that we're actually interested in them. So recently, with all the controversy and deaths in opioid prescription use, misuse, and abuse, a lot of attention is being paid to pain medications. So we really need to leave it up to the person working in collaboration with us to really determine what type of pain is going on and then how are we going to take care of it. But I want you to think too that as we get ready to talk about the NPAs, that medication and NPAs are with one another. They're adjunct to each other. And we need to use them at the same time. And then you need to know what works and does not work. And then to be sure that it's documented. It really is trial or error. We shouldn't give up after we've tried one NPA and then we don't try anything else. But we also have to give it some time. And we have to incorporate things over time. But you don't want to do too many approaches or meds at the same time because then you don't know what worked or didn't work. So in geriatrics, I would hope that those of you who've been educated in gerontology and aging know that the rule is you add one thing at a time, see how it works, then document how it works, and then figure out how you can proceed. And that's very important. So let's talk about some underlying principles of pain, which I think are very important. Bottom line, effective pain management is a moral imperative. It's a professional responsibility and it's the duty of people in the healing professions to make sure that we're asking about, recognizing, and treating pain appropriately. Chronic pain has a distinct pathophysiology. It causes changes throughout the nervous system that often can worsen over time. It has significant psychological and cognitive correlates and can constitute a serious separate disease entity that maybe if we would have paid attention to the pain, we could have diagnosed the underlying condition sooner rather than later. Because we do know that the sooner we diagnose, treat, and manage in a comprehensive way, the better things are. And then given chronic pain's diverse effects, really an interprofessional assessment and treatment may produce the actual best results for individuals with the most severe and persistent pain problems. Chronic pain has such severe impacts on all aspects of daily living that every effort should be made to achieve both primary prevention. So if somebody falls and fractures a hip, they have surgery. And secondary prevention. So preventing acute pain to become chronic pain. If we treat the acute pain, then we can prevent it in most cases from becoming chronic. And this is done through early intervention. Well, there's a lot more to be learned about pain and its treatment. Even existing knowledge that we know is not utilized effectively. And that's why opioids have become a huge problem, one reason. And substantial people, numbers of people, and more people are being impacted all the time. So pain meds need to be prescribed appropriately and monitored. They can be safe and effective, especially for acute, post-operative, procedural pain, as well as for individuals near the end of life who desire and deserve more pain relief. So the effectiveness of pain treatments depends greatly on the strength of the healthcare professional and the patient relationship, and that there's a therapeutic, trusting relationship that starts everything else from that foundation. Pain treatment is never about the intervention alone, but about the healthcare professional and the patient and the family working together for success. So non-pharmacologic approaches or interventions, CMS calls them non-pharmacologic approaches, are ways to decrease pain in addition to medication when it's necessary. Effective chronic pain management often requires more than one treatment approach, so that's very important. A pain management plan should include both medications, that could be prescription or over the counter, and non-pharm approaches and strategies. And then finding the best therapeutic regimen for a particular individual may also involve several trials or different strategies before you arrive at the one that works best for them. So we really need to be encouraging patients and their families to be hopeful and also patient, because sometimes it takes a while. So the use of NPAs actually provides an opportunity for constructive and meaningful interaction that leads to better patient outcomes. And then what are the advantages of NPAs, which are the non-pharm methods? It increases the individual's feeling of control over their own life and body, decreases feelings of helplessness and hopelessness. It improves activity level and functional capacity, and we all know the unfortunate results of lack of activity. It reduces stress and anxiety, reduces the pain behavior and focusing on the pain rather than living life. And then reduces the needed doses for analgesic drugs. And then that decreases side effects or adverse events. And bottom line, by not having to live with pain or living with pain that can be treated, really leads to creating those memorable moments, which is what we should be about in healthcare, because we always can't cure. But we can care, we can get to the bottom of issues that individuals face and help them to live each day to the fullest. So we shouldn't be using NPAs in place of appropriate medications, but as I've said, as an adjunct, and utilize as soon as possible. Those of you who have attended webinars that I've done or conferences that I've been at know that I always say the most important thing is knowing the individual story or the person's story, because none of us are alike. We all have a past history, different habits, activities, likes, dislikes, all of those things, different life experience with pain, how we cope with things. What about their bucket list? How do we know how to treat a person if we don't know what they're hoping for? And then individualizing the approaches, because the personal story of pain can be transformative, or it can blunt the human values of joy, happiness, and even human connectedness. And this is where really healthcare professionals come in. Many of the intervention strategies and techniques require active involvement from the person living with pain. So in many cases, they need to be cognitively intact. And the involvement helps build self-reliance and a sense of control over the pain, which is very important. And there's lots of myths and stereotypes about pain. We don't have time to go over all of them today. But when pain can be ascribed to an underlying disease, such as cancer, then it's accepted as real and treated with concern. But when healthcare professionals have difficulty in validating the pain, then is it because they're mentally ill? Is it because they're having psychosomatic, body-mind issues? And sometimes we give up or we question the person. And I think that happens a lot depending on the person's history and the person's story. But we need to understand, and we need to understand their past experience so that we can help them and that we can get to the bottom of the issues. And sometimes maybe it is emotional or spiritual pain or psychosomatic. And if we find out, what is going on in their lives, then we have more information from which to make our diagnoses and treatment plans. So when we're talking about NPAs, they can be classified in different ways. Really, they deal with physical, cognitive, behavioral, and other complementary methods. And they can either be invasive or non-invasive. So I have included in your handout lots of NPAs for you to think about. If they have an asterisk, they're evidence-based, meaning that there's been enough research done that we look at them and there is evidence for them. Now, we still need a lot more research. There are things, interventions and strategies and techniques in this talk which I've seen work in my practice as a nurse practitioner since 1989 with older people, especially those with dementia. And there's a lot of articles and information out there that just haven't had big studies done. So I'm going to just talk to you about some of the approaches in your handout. I want to talk about physical activity. I don't use the word exercise anymore because it really sends chills down the spine of people that are already in pain because it's hard for people. Physical activity can be a lot of things that really lead to relaxation and calm. It really needs to be meaningful to the individual, and it needs to be intentional. But it can be the things that people do on a daily basis. Brushing teeth, taking a bath, drying off, washing dishes, preparing, walking to maybe the mailbox, doing laundry, doing yard work. People don't have to belong to gyms, and we need to encourage them to do different types of physical activity. One of the ones that I want to talk about that's available in most communities, even in rural communities, is hydrotherapy. Really what that is a medicinal use of water. So that could be hot tubs, cold water treatments, ice packs, saunas, mineral springs, hot springs, sitz bath, wet towel applications, water exercises, water massage. There's pros and cons for how we determine what is most beneficial for that individual, and then of course their preferences. But hydrotherapy immersion waters available at spas also sometimes have like minerals, or they've been enhanced with aromatic oils or herbs, which aromatherapy is also something that can be therapeutic for people. But you have to know if they have any allergies. If they have, asthma, eucalyptus is not, or lavender, neither one with a person who has asthma is very therapeutic if it causes a negative response. So just because you have 10 people that you know who lavender is wonderfully therapeutic doesn't mean it's going to be for everybody. So we have to really, really think about that person as an individual. And then the great thing about hydrotherapy is it increases blood circulation and increases the body production of endorphins. Endorphins that we know actually help to get the brain not to think so much or concentrate so much on the pain. Doesn't necessarily take it away, but it gets the person to think about something else. So enhanced circulation then strengthens the immune system, reduces inflammation, can actually heal injured tissue. This is why we use it a lot for sprains and strains. It then can improve well-being and energizes the body. Yoga. It's not for everybody, but it does provide relaxation by using respiratory exercises and meditation with slow movements. I saw on the national news, I think it was last week, a 105-year-old woman, and they went to the yoga studio where she goes. Oh my gosh, it was incredible. And She told about why she thinks she's at 105 and she's always done some kind of physical activity. So it depends on the person. Yoga can be useful for musculoskeletal pain in terms of using physical stretching and really increasing strength. So think about that. Animal assisted therapy can effectively be used as a complementary therapy to reduce pain along with reducing stress. This can happen in hospitals where they actually have programs, therapy dog visits in an outpatient setting. One of my colleagues who runs an FQHC in Battle Creek has always had a lab who patients know. The dog is there every day, and patients look forward to visiting with them. Therapy dogs can significantly improve emotional distress and feelings of well-being in family and friends who are accompanying patients for appointments, and even the clinic staff. I'm in clinic on Tuesday, and every Tuesday from 1:30 to 2:30 we have pet therapy. And I'm really sad when I can't make it down to the room to actually get to be involved in that, because it's very therapeutic for me. But it's not just dogs or cats. Farm animals, reptiles, it doesn't matter. Lots of things are therapeutic. And I believe that I have seen miracles occur with some of these interactions. People who don't talk because of post-stroke, who actually can talk to the animal. They don't talk to people, but they talk to the animals. So you need to be open for this type of thing. I want to say something about assistive devices. If a person has glasses, they should be up to date and they should be clean. I have seen most horrible glasses where no wonder they can't see and they feel disoriented because they're dirty. Or hearing aids. If they have a hearing aid, they should be wearing it. Just because it's in the ear doesn't mean it's working. So batteries need to be checked. They need to be cleaned. It's kind of gross if you look at some of those things. And then we put them in their ear, dirty again? No, let's clean them up. That really, really helps. All canes are not the same. It depends on your height. And what kind of cane depends on your disability. So a person that's 6 feet is going to require a different kind of cane than a person who's 5 feet. They shouldn't be bending over, stooping. So, and the wheelchairs and walkers, they're all different. They need to be fit to the person, and then if they have them, they need to be using them. And shoes and clothing. Yesterday at a family conference, we were just having this conversation. I'm sorry that you think that if you wear underwear larger than a size 10 for women, that you're too fat. If you insist on getting size 8 underwear and the circulation is cut off by the elastic, then I think we need to think about the person, not the size. Same thing for the elastic pants. If it's squishing them, it's probably not very comfortable and causing pain. So we need to think about this. I'm just saying. Just yesterday. Okie dokie. So, bathing alternatives. It is not easy necessarily to get an older adult, especially if they have some kind of cognitive impairment or dementia, into a bathtub. So, Bathing Without a Battle is a program that combines person-centered techniques with simple, practical approaches to making showering or bathing either in a tub or bed, and hair washing safe and comfortable for the person giving and receiving the care. You know, when staff come up to me and said they don't want to get beat up today because so-and-so is not happy and angry, I'm like, guys, don't take them to the shower. They don't like the shower. They have bad experiences from the shower. So let's do it in a more creative way and get them to be involved. So bathing against a person's will goes on all the time. And of course, if you don't want something, you're going to be mad. If people don't listen to your words or don't understand your words, then you're going to resort to physicality. So we need to think about it. Biofeedback basically teaches the body to respond differently to the stress of being in pain. Biofeedback can be used for the treatment of migraine pain, spinal cord injuries, and movement disorders. It's aimed at control of the physiological reactions such as muscle tension, body temperature, heart rate, brainwave activity, and other vital parameters. So basically, efficiency of the treatment depends on the desire that the individual patient shows for learning how to control these functions, and the participation of the patient in the process is really essential. So individuals with dementia, really, this is not necessarily the best way to go, except we're always doing new research, new studies on biofeedback, new sensors where caregivers or individuals can actually help the person to learn, and then they're looking at the screen to seeing what is it that they're trying to achieve. Something to think about. Communication with patients should be therapeutic and has been shown to be as effective as medication in the management of chronic pain. So the words patients in pain here can either empower them or cripple them. And as healthcare professionals, people that work with people that are potentially in pain, it is extremely important for each of us to really evaluate our own narrative, our own responses, our own thinking about pain. And think about our delivery style, tone of voice, our body language, how our conversation comes across to the individual, and really your power of persuasion. Families always tell me that their relatives will do whatever I say. And that's pretty much true. But then, in order to make them feel better, I say, yep, but nobody in my family does anything I say. So there you go. It's a family thing. It's not a miracle thing on my part. That's just the way it is. So I think my brother thinks, my mother thinks my brother, the minister, knows more about healthcare than I do. So I've just come to know that that's just the way it is. But persuasive communication can improve patient satisfaction, family satisfaction, and can actually lead to an adherence and positive treatment outcomes. So think about that. This slide is really more about communication and really thinking about that we should be talking in neutral I responses. You know, I understand, not you said, or it's got to be about us. And we need to think about the individual, and any social pressures, cultural expectations is huge. We should know something about the culture of our individuals, especially if it's different than our own, especially if we have large groups of different cultures or ethnicity within our practices. Then we should really read about those cultures and then also ask the person, because that's where we learn the most information. And then we also have to understand health literacy principles, and really that's about at a 6th grade level, regardless of whether people have a college education or not. Cognitive behavioral therapy is a type of psychological intervention that truly can be a mainstay of pain management, and it is a recommended intervention for treatment. There is strong evidence for the effectiveness of CBT, especially when the focus is on developing cognitive coping strategies and behavioral rehearsal. Most of the evidence that we have is actually available for adults, but they're actually starting to do a lot with adolescent chronic pain and CBT. So behavioral rehearsal is really working with a healthcare professional on how am I going to respond if this happens. Sometimes it can be about role playing, but if somebody says this to you, how are you going to react? Alrighty, so I think that that's important to think about, and I could talk the whole rest of the time on CBT because I've seen incredible things happen with it. But it does take the individual being engaged in the process. Chirotherapy, or basically ice, helps decrease swelling and pain and can also prevent tissue damage. So you can use an ice pack or put crushed ice in a plastic bag. It doesn't have to be fancy. Always needs to be covered with a towel or blanket. Needs to go on the area for 15 to 20 minutes, never directly on the skin. Running cool water over a scrape or a burn, mite or cut, cleans the wound but also cools the burning. The sound of running water can also be soothing, so there's lots of great things going on. Sometimes even a cool cloth on the forehead can help with a headache. Ice can be immediately effective in relieving pain, especially pain caused by bruising, muscle spasms, sprains, strains, insect stings, bites. It really acts like a mild local anesthetic. There's also alternating ice and heat, because that can be effective strategies for swelling, muscle spasms, sore joints, but especially with older adults, just because their proprioception, their sensory stimuli is decreased, their hypothalamus and their temperature gauge is different. People think that, gosh, I'll put a heating pad on it. Heating pad should never go over ointment. It should go onto the skin or onto a towel over the skin. And just because it feels good for 15 minutes doesn't mean you should leave it on all day. I've seen third-degree burns from heating pads. You have to be extremely careful. There is such thing as too much of a good thing. Consistent daily routines are very important, but not in our time or what's convenient for us, but when the person wants to do things. Not everybody likes to eat breakfast at 7:30 in the morning. So not everybody likes to get up early or take a shower first thing in the morning. So if we really are practicing person-centered care, it's individualized for the person based on their preferences, and they should have choices. So some of our basic functions like sleep and hunger, digestion, alertness, toileting are basically based on cues from our environment. If everybody's eating, do we think that, well, gosh, maybe we should be eating? Or if everybody else is in bed, does that mean we should be in bed? Although they can be influenced by many factors, basic drives remain in place. So if somebody tells me that our new resident with dementia is sleeping during the day and getting up at night, one of the first things I ask them is, what did they do for a living? Because if they work midnight shift, guess what? That's when they were awake. And so we have to understand that in order to get them to get used to the routine that is their routine. A lot of behaviors develop from this kind of thing. There's a lot we can do about the environment that can potentially impact pain. Making it appeal to older adults, which is not the color that you necessarily like or the lighting that you like. Position changes are very important. And really, positioning has been determined as the most common post-operative, non-pharmacologic approach that we can have. So we need to think about that. I said a little bit about heat. It really helps decrease pain and muscle spasms. But it's for 20 to 30 minutes, maybe 3 or 4 times a day. It's not good for everything either. There's a difference. So as healthcare professionals, we need to know, when should it be heat? When should it be ice? So I want to say something about laughter, because laughter is a powerful antidote to relieve stress, pain, conflict, anger, fear, depression, and hopelessness. Genuine laughter does release endorphins in the brain, and having a good sense of humor can have positive effects on the body. I do a lot of talks on humor and laughter as therapy. And some of the best humorous moments or jokes, although humor and laughter is not necessarily about jokes, have been from older patients and other family members. And when I do talks in the community, I always steal a couple of the stories that they tell because they're good to share. And you all have stories. If we work with people, we have stories. If we live life, we have stories. We just have to take ourselves lightly. And I document funny things about the person's life that they tell me about in the electronic health record, so that when I see them and they might be down, I'll say, remember the time when Bubba was their brother, did this? And that is life review and reminiscence as well, and it's a good thing. So, listening non-judgmentally to the person's fearful explanations of their pain, no matter how bizarre it might seem to us, can give valuable insight into what is causing distress and halting any progress in treatments. You need to seize the moment. If they talk to you about myths or false beliefs about pain or pain treatment, that is when you should tell them what the facts are. Because we really need to be instilling hope in people. Sometimes it's because they have no hope. That when we think something should be working, especially a certain medication, if we're asking them to take it and they're taking it accurately, why isn't it working? So if we're talking about active listening, then it means that we're generally interested in understanding what the person is saying, thinking, and feeling. Reflective listening is distinguished because we check out our understanding. So if you are telling me something, I would say back to you something like, well, what I understood from what you just said is, did I get that right? And if not, it gives them the opportunity to correct it. And then that's also a time that if they're using specific words, then you can put that down so that you remember. And then comprehensive listening involves understanding the message or the messages that are being communicated to us. And, discriminatory listening is really developed at a very early age. Some people even say in vitro. If the child is listening to what's going on, depending on what your personal beliefs are. But it's the most basic form of listening. And it involves not only the meaning of words or phrases, but the content, the change in voice or tone, loud, soft, and being able to discriminate. And what does that say? Sometimes when I ask a person, how are you feeling? And they say yes, I tell them, I don't think that's true, because of all the other factors. So it's not just the word, it's other things too. So practicing listening skills. And sometimes when we practice listening skills on our family and friends, that's the best way to do it because we can live with their criticism. And then we get to be better at it with our patients. Pain affects every aspect of life. It can challenge or change the activities a person does, sleeping, eating, socialization, and much more. So positive lifestyle changes can help manage pain. 2 starting points would be to eat in a healthy manner and maintain a healthy weight. Meditation is generally focusing on the moment or focusing on the present. This is accomplished with the patient focusing on their own respiration, a word, a picture, a vision of something pleasant that they would think of. And duration of meditation can last for a few minutes, 30 minutes, or take more. It really helps the person to relax and is very effective in relieving pain. And that's kind of like guided imagery, where we teach individuals ways to put pictures in their mind, not that we think are restful, but what they think are restful. And it can make the pain less intense. It can actually help the person learn how to change the way their body senses and responds to pain. So music may help actually increase energy levels and improve mood. I could talk all day on this, and I believe what I have seen miracles occur, especially in post-stroke patients with aphasia who cannot carry on conversations, but if you play music on a piano or guitar that they know from when they were younger, they know all the words and they can sing and do sing along. So music reduces pain by triggering the body to release, once again, those mighty endorphins. And those endorphins actually release chemicals that decrease the pain. And many studies have been done that have shown that music has positive effects on pain and anxiety and increases the living quality of the person. It reduces heart rate, blood pressure, body temperature, and respiration, and it detracts the attention of the patient to another something going on, thus reducing the pain perception. So remember, it's not about, if you like country, please don't play it in my room. I like some country, but not all. If you're hip hop, good, there's some, but don't play what you like. The person's like is what we are trying to get at. Alrighty, so empathic presence is an interconnectedness and lightheartedness that optimizes strength. Presence is basically the state or fact of existing, occurring, or being present in a place or thing. You, in your presence, with your patients, can be therapeutic and can be a non-pharm approach. I just want to say a little bit about religion, spirituality, and faith, because spirituality has been defined in lots of ways. Belief in a power greater than self, sense of connectedness with all living creatures and nature. Spirituality is a part of every human being, mind, body, spirit, biopsychosocial, spiritual. It's not necessarily about religion. But more and more people are becoming more interested in the spiritual component. And it's been suggested that praying or meditation reduces depression and anxiety that's caused by chronic pain, by alleviating stressful feelings and promoting healing ones. Spirituality can positively impact the immune and cardiovascular system. So self-management, what I do want everybody to think about is that many areas on agency, which are in every county in this state, have chronic pain self-management classes. You just need to contact your office area on agency and find out if they have one. I know in Ingham, Clinton, Tri-County, Ingham, Clinton, and Eaton County, they are starting a chronic pain self-management, but there's also all over the state. Those are wonderful. They're generally 3 or they ask for a donation, but it's going once a week for 6 weeks, and people are with people that are experiencing the same thing they are. And most leaders are people who have lived with the chronic disease that they're talking about or the pain. Sleep hygiene is very important. Reading and watching TV in bed is not necessarily a good thing for everybody. Bed should be for bed, and we won't talk about sexuality in this talk. I suppose that could be used there as well, but we're not talking about that today. So, therapeutic use of self, that you are the therapeutic approach. The sense of touch, weight reduction, we have already talked about. So what are some of the pearls that I want to leave you with? Pain is always subjective. It can exist even when no physical cause can be found. I would like you to think that and assume that older adults with cognitive impairment or dementia have pain if they have other chronic conditions that are typically associated with pain, like arthritis, kyphosis, diabetic neuropathy. And all people are unique individuals, and their options and choices for them that work for them are most important. A uniform pain threshold does not exist. A pain assessment should address physical, psychological, cultural, and spiritual aspects of pain. And NPAs are effective, but you gotta know the person's story so you can bring to them the best treatments. And we all need to be proactive, preventative, positive, and hopeful, because optimal pain management is the right of all individuals and the ethical responsibility of all healthcare professionals. So the outcomes are, we certainly want those endorphins to be released because that helps decrease the perception of pain. Overall, we want them to be less fatigued, to have more energy, for their circulation to be better, to be more relaxed, to decrease strengths of medications or medications overall. We want to have an improvement in quality of life. We don't want them to tolerate pain or to have to live with pain. We want to give them ways in which they can live and have the pain be as minimal as possible. And we want people to have hope, and certainly to decrease morbidity and mortality associated with pain, and certainly then to change the way people use healthcare and thus decrease costs. So, my final quote, knowing about pain is not enough. We must apply the information. Willing is not enough. We must do. So thank you.
We will now take questions and comments. So please state your site name first and then ask your question. So are there any audio sites or video sites that have any questions?
No questions, thank you.
Okay. Are there any other audio or video sites that have any questions?
Hi, this is Mary with Area Agency on Aging of Northwest Michigan.
Go ahead.
Have you heard of associative awareness technique?
No, I have not. But I'm writing it down.
It's something it's very new to me too, and I'm looking for more information.
Well, Mary, send me your email address or send it to Victoria, because I will look it up. And if I find anything exciting, I'll be happy to email it to you.
Okay, I did find there's like 3 steps to it. I found a training that could be purchased. I thought I'm not ready to purchase any training yet. I want to just look into it, do some research. And,
Right.
It deals with brain mapping and muscle memory. But it looks pretty interesting and intriguing. So
Very good.
I will get my email to you. So thank you.
All right, thank you.
Right, bye.
Bye-bye.
Are there any other questions or comments?
Yes, this is Norma Bohr from Area Agency on Aging in Kalamazoo. And I just have this comment and a thank you. One, thank you for mentioning that chronic pain path self-management is available through the Area Agencies on Aging. And I do want to emphasize as well that it's valuable for caregivers who may be able to assist and better understand what their loved one is going through with pain if that person or if that person cannot get to the workshops themselves. It's valuable for the caregiver to participate as well.
Very good, thank you.
Any other questions or comments?
Thank you.
The marketing call.
Thank you from Munson Hospice Grayling.
You're welcome.
Hi, Iron Mountain, Michigan. Iron Mountain, Michigan has a question.
Go ahead.
Thank you. Just in your research, Linda, I think some of the barriers to some other alternative pain management techniques have come in funding and just availability through insurances. Is there any kind of movement that you see happening maybe for acupuncture, other forms of treatment that might be coming of age? Thank you.
Yep, actually, acupuncture is one of the approaches in the list that I gave you. And there's a lot on the list in that handout. And then there's a lot of references and resources at the back of that handout. What I did was use mostly evidence-based because that is really what a lot of healthcare systems and practices are looking for. However, as I said, there's lots of things in there that don't have an asterisk in front of them that I know that work and that other people know that work. It's just that they haven't done big studies that can be replicated, and that's the issue. However, I think there's many, many, many things that we can do in order